So now we have Dr. Anagha Heroor, Senior Consultant at Anil Eye Hospital, talking on leveraging light, differential light distribution IOLs.
Thank you so much, everyone. A very good afternoon. And thank you, Dr. Sri Ganesh, Dr. Supriya, and team Nethradhama. I'm extremely sorry that I was not able to be present there. And I know definitely I've missed seeing so many of you as well as the great event. So I would be speaking on leveraging light differential light distribution IOLs. So as we all know, there are multiple challenges in multifocal IOLs. Most importantly, we need to select our patients, select the kind of lens that we are going to use. And yes, counseling of patients and a precise biometry and surgery are extremely important. So to have a perfect biometry, we need to have a pristine cornea. We need to ensure that the ocular surface is good. Check whether on topography, if the astigmatism is regular or not, and also look at the OCT. Now, if the patient has astigmatism, what we usually do is put in the K1, K2 readings on the Barrett online toric calculator, and that decides whether the patient needs a toric or not. And that is why the number of low-powered torics that we are using nowadays has definitely increased. We need to discuss all the various options available to our patients also. So basically, for deciding a patient whether he needs a toric multifocal or a multifocal IOL or an EDOF IOL, we need to communicate with the patient, understand his work-related activities, what are his lifestyle choices and personality, what are his expectations, and then decide about the IOL. So you need to understand whether he does any night driving, how much of reading and how much of intermediate work he does. So if, for example, if the patient has a lot of intermediate work, we need to give them either a trifocal or an EDOF with micro monovision, and also counsel them about glare and halos if he is doing a lot of night driving. If the patient is okay with the glare and you have decided to go in for a trifocal IOL, computer work is something which is very important. And sometimes the patient also, you also need to understand his reading requirement, especially the distance. So you decide the near addition depending on his reading preferences at the distance, and do not ever promise for 100% spectacle independence. Now, today we have a lot of choices, and one of the best lenses that we have today is the Vivinix Geometric Trifocal family, which has two lenses, the Geometric as well as the Geometric Plus. So basically the intermediate and the near add for them are both the same, that is 1.75 and 3.5. So where does the difference lie? The difference lies in the differential light distribution. So if you look at the Geometric, it has almost a 50% distribution for distance, and the Geometric Plus has almost a 32.8% distribution for near. A combination of these two lenses gives us excellent distance vision with the Geometric and excellent near vision with the Geometric Plus. And both of them will give good intermediate vision. So pairing the Geometric with the Geometric Plus gives us excellent vision at all the three distances. So there was this Nino study which looked at the clinical outcomes with various combinations of Geometric Plus, as well as both of them. And if you see the binocular defocus curve over 4 to 6 months post-op, you see the red curve here. It gives us excellent distance, good intermediate, and an excellent near. So it found that the pairing of the Geometric with the Geometric Plus provides the best balance of the high quality vision. So the one in orange that you can see here is the one with Geometric and Geometric Plus, gives us excellent intermediate and near vision. So more than 90% of these patients never used glasses across all distances. In my personal clinical experience, we have used more than around 170 lenses now till date. And we all know, we have already seen a lot of other surgeries today, that for a trifocal IOL, it's very important to have a perfect centration and a good stability. So a good CCC is important, and the Vivinix platform also has, as we all know, has excellent stability, is very good for the very smooth implantation. And as you can see here, there's a perfect centration and stability because of the sandblasted haptics and the optic edge. So in our patients where we used bilateral implants and studied them 2 months later, we found that the spectacle usage at various distances was almost nil. And in fact, the light intensity for near vision for a paired approach was a minimum. It was just around 255 lux for a patient for near vision. Then if you look at the various dysphotopsias, now we all know that with the diffractive lenses, definitely there is going to be some light loss and some kind of dysphotopsias, but they are at a minimal, whether it's glare or halos or starburst. And patient satisfaction for all distances was almost around 99 to 97%. So regarding spectacle independence for patients, regarding dysphotopsia and patient happiness, in all the three levels, the patients were really very happy. So this was one of our patients. This was just 1 day post-op, and you can see that the patient was already able to read very well at the ambient light that was in our clinic setting itself, and she was able to read very, very comfortably. So the patient was extremely happy. So if you have an unhappy patient at the end of surgery or after a few days or weeks, you also need to remember that you need to look at various factors, whether the other eye has been operated or not, whether there is any residual cylinder or refractive error, whether there are just fine folds in the pupillary area. Look at cystoid macular edema, especially around 3 to 4 weeks post-operatively. See if the corneal and ocular surface is a little compromised. Look at the centration of the IOL. And you need to also explain to the patient regarding the reduced contrast sensitivity, glare and halos. And over time, they usually become more adjusted to it and neuroadaptation sets in. Counseling of these patients is extremely important, that they need to use a little more light for reading. They need to have realistic expectations, and we also take a special consent for these patients. So at the end of the surgery and the end of the patient's experience, the patient is happy because he has got a good visual outcome, spectacle freedom and minimal dysphotopsia, and the surgeon is happy because of the ease of implantation, the preloaded advantage, the clarity with the Vivinex quality of lens, and all this boosts our confidence definitely. So these promising newer technologies help us to get better visual outcomes and happier patients. Thank you so much for your kind attention. Thank you.